Good afternoon. At least in our country, it's the Netherlands, it's afternoon. Maybe not in all your countries, but still very welcome to this webinar on behalf of the International Collaborative for Best Care for the Dying Person and on the EAPC Task Force on Care for the Dying. Today's webinar is about experiences and preferences of people in the last phase of life. And the presentations are based on the 11-country iLIVE project we have conducted in the past couple of years. The webinar includes presentations by Dr. Maria Schelin from Lund University in Sweden, from Ber van Yildiz, who is a junior researcher from Erasmus MC in Rotterdam, a colleague of mine. And we will have a presentation by Melanie Yoshi, a junior researcher and research nurse from the University of Cologne in Germany. I will, as a brief introduction, show you a few slides which are hopefully visible now. So this is the program of today. The International Collaborative is an organization with currently over 700 members from virtually all continents around the globe. And with the collaborative, we strive for a world where all people experience a good death as an integral part of their individual life. And we hope to contribute to that by providing the very best personalized care. The collaborative engages in different types of activities to achieve that aim. We do research and development projects. We have learning and teaching opportunities, and we have a program for quality assurance. And one of the central assets in all these activities is the model for best care for the dying person that has been developed within the international collaborative context, and which is also referred to as the 1040 model. Since a couple of months, we have also been assigned the role of EAPC Task Force on Care for the Dying. So we are very happy to have this connection to EAPC land. What we do in this context is that we provide a multi-professional network and forum within EAPC context, that we organize webinars such as this one, but also distribute newsletters and have a website. We promote sessions at each other's international meetings, and we have started to work on a white paper on best care for the dying person on behalf of EAPC. But today the focus is on our webinar. As I said at the start, we have 3 presentations. I would like to invite you, if you have questions or points for discussion based on a presentation, after each presentation we have a couple of minutes for discussion and for such questions. So that as an introduction, for now, I would like to invite the first speaker, Dr. Maria Schelin, to talk about the iLIVE study, and especially about how recruiting and involving patients in a big study such as the iLIVE study worked out and what the challenges are. So Maria, the floor is yours.
Thank you very much. Let me see if this works. Yeah. So everybody can see the screen, I think. This is the paper that I will be talking about today. The title is Recruitment, Follow-up and Survival in an 11-country cohort study of patients at the end of life and their relatives. And that is, of course, the famous iLIVE study. All right. So here are the authors. Carl-Johan Fust is the last author, but of course on behalf of the whole iLIVE consortium. And this paper has been submitted to clause 1, and the abstract was also presented at the International Collaborative for Best Care of the Dying Persons summer school in Malaga this spring. So the aim of this particular sub-study out of iLIVE was to present data on recruitment, completion of follow-up questionnaires, and survival of participants recruited to this international cohort study at the end of life, and importantly, thereby inform and facilitate future studies in this field. So we acknowledge that this data is, well, kind of dry, and in iLIVE we have the participants that we have. But if we would have had access to this type of information when we planned iLIVE, I think that would have been useful. So the aim is to provide future researchers with that data. So as you can see here, it's all these countries that have recruited patients, and the patients were selected based on the 6-month surprise question. At inclusion, we asked patients, a family member, and the treating physician to complete baseline questionnaires. For the patients and family, this was, I would call, very extensive questionnaire. For the physician, it was rather short. 1 month after inclusion, we sent patient and family member a follow-up questionnaire. And then after death, quality of care during the last week of life was collected either from the treating physician or care team or from medical records. And 3 months after the death of the patient, the family member received a post-bereavement questionnaire. So we will, this paper will focus on the 1 month follow-up. But first of all, together, all our countries screened 26,000, over 26,000 patients, whereof 73% did in fact not fulfill the inclusion criteria. The most common reason was that the expected remaining lifetime was more than 6 months, but also that the patient was not aware of his or her prognosis or was not cognitively capable of giving informed consent, were relatively important reasons for not fulfilling the inclusion criteria. So 27%, just above 7,000 patients, did fulfill the inclusion criteria. And out of these, almost half, 46%, did also, unfortunately, fulfill the exclusion criteria, where the most common actually was recorded as other reason. So before starting the recruitment, we had identified that if death is imminent or if filling in the questionnaire is in fact too burdensome for the patients, that would be exclusion criteria. But obviously there are also several other, well, one or several other reasons that were in fact more common. So in addition to the patients who fulfilled the exclusion criteria, there was a number of patients, 808, 11%, who, despite fulfilling the inclusion criteria and not fulfilling the exclusion criteria, still was not invited to the study. And the reason is unreported, but we have reason to believe that it is, in many cases, it is due to that the patients were in fact discharged from the hospital before the researcher could ask or invite the patient to the study. So the number of patients asked for participation or invited to the study was just over 3,000, 42%. And of these, almost half, 49%, accepted and agreed to participate in the study. Of these, we also asked for if we would be allowed to ask a relative if this family member would also fill in a questionnaire, and we were allowed to ask, and there was an available family member in 69%. And also in the case of the family member, a majority, 60%, agreed to participate when asked. So the final study population is still somewhat lower than the number of patients included. It is 1,425, because a small number, 84 patients, were in the end not included in the study population since there was no available data, no questionnaire from patients, nor from family members, nor from physician, nor from medical records, and thus there's nothing to analyze on these participants, even though they did agree. So this, I think, is a rather beautiful picture made by Sofia Sombrano, a colleague in iLIVE, which shows visually this huge proportion of patients who were screened and then in the end either not included or excluded, and kind of put into a picture all the work that was done in order to end up with this final study population of 1,425. So we move on to the frequency of follow-up questionnaires completion. This slide is somewhat busy, but in the blue bar, we show the number of patients who die each month after inclusion into the study. So, for example, 253 patients died in the first month of the study, after being included in the study. The yellow bar shows the number of patients out of those that died in that particular month who completed their 1-month follow-up questionnaire. So in month two, after inclusion, 188 patients died. 46% of the patients had actually managed to complete their 1-month follow-up questionnaire. That is in the month before. And the green line and the right-hand y-axis show the proportion of patients completing their follow-up questionnaire. And as you can see, that proportion increases throughout the study period and actually reaches 84% for patients who died in the 6th month after inclusion. And this is a box plot showing the survival time in days over main diagnosis. And here we restrict our analysis to patients who survived 1 year or less. And as you can see, the survival times are relatively similar over diagnosis groups, except for neurological disease, which these patients do have a longer survival time. But we need to note that in the entire sample, there were only 15 patients with neurological disease. So even though it's statistically significant, we need to bear in mind that the numbers are low. So our main result is that approximately 20 times the desired cohort size had to be screened for eligibility. And in fact, prognostication is very difficult, and we know the wide distribution of survival after inclusion into the study when we base inclusion on the 6-month surprise question. And of course, patients' ability to complete follow-up questionnaires decline, and they decline well before death. As I just mentioned, we saw that trend over all of the 6 months. So from another angle, only 11% of the screened patients were eligible, but when asked about participation, about half agreed to participate, which I think is a both high and humbling number, actually. The willingness or ability to participate in follow-up naturally decreased significantly as death approaches, and we don't know whether that trend would continue after the 6 months. So we concluded that end-of-life research does in fact pose several specific challenges. For example, prognostication, which is, notoriously difficult, but it is of great importance even when we plan such a short follow-up as 1 month. Recruiting participants in this context really requires effort, and it was one of the concerns in the iLIVE study that recruitment was slow or difficult. But once identified, patients and relatives are often willing to participate in our research, which is very encouraging, actually. Thank you.
Thank you, Maria, for your interesting and thoughtful presentation. As stated, please, if you have questions, put them in the chat or simply raise your hand, your virtual hand, so that I can give you the floor. But as a start for a discussion, Maria, I would like to ask you, I think your presentation is about 2 issues. The first is how to efficiently recruit patients, how to efficiently try to find the right target population for a study like this one. And secondly, if you have found those patients and they have agreed to participate, are they indeed the the patients we are looking for? Are they indeed the patients who have a limited life expectancy, as was the goal of this study? And with regards to the first issue, how do you think recruitment could have been more efficient? What would be the most important measures to avoid having to screen such a large number of patients to find the right number of people in the end?
Well, golden question, isn't it? But I think we didn't look at the specific, in this paper, we didn't look at the reasons or how to make screening more efficient. I think our underlying aim was more to say that if we would have known that we would need 20 times the number, to screen 20 times the number we needed to end up with, could we have planned differently? I think at least in our case, in Sweden's case, we would have had more sites from the beginning. So that is of course one thing. Another thing is that when you look at these data country specific, as it turns out, these two countries that has done almost all of the screening, with rather low percentage of patients being included, obviously. And I think it depends on how you choose to screen. You might screen on different levels of the system. I think it was Switzerland and Germany who managed to screen this enormous amount of patients, but on a rather high level, so that you would then have to screen very many. But if you include patients in a specialized palliative care clinic, for example, then the number of patients who didn't fulfill the 6-month surprise question would be virtually zero. So in the end, I think we need to know more about the different sites, but also have respect for the fact that countries and sites differ, and that one solution might not fit all.
Mm-hmm. Thank you. And the question regarding the second issue, did we indeed include the patients we were looking for? I think we all know that the surprise question in principle is not a question that is aimed at giving a very precise estimate of the remaining lifespan for patients, but still we tend to use it in that way also for a study like this one. Could you give your view on that? Is the surprise question an appropriate tool to identify patients eligible for end-of-life research like the iLIVE cohort study?
Well, I think it's the question is I know I've been led wrong sometimes by the question, because you think if it is that it's supposed to estimate people who will survive 6 months precisely, and as you said, that's not the aim, and it's also, I mean, obviously impossible. How could we? So I think that we, in the end, did manage to probably identify the patient population that we needed, but sometimes in discussions or how we thought about it was that everybody would be dead within 6 months, but that's not how the question is posed, and of course it does not identify the people who need palliative care. It's enough that the answer to the 6-month surprise question is no, then it might indicate palliative care needs, and also which I think was the population that we wanted to reach. And then, of course, there's always these miracle patients or patients who were wrongly identified and could go. I think we have patients in the data material that lived for 1.5 years or more after inclusion, but it's a small proportion.
Yeah.
So in general, I still think it works, but it needs continuous evaluation probably.
Thank you.
Thank you.
If there are no questions or discussion points from the audience, which there are not until now, then I would like to ask Jo, can you start up the second presentation by Berre van Yildiz, who is she's not able to be present live because she is currently on her way back from her holiday, but she pre-recorded her presentation. And if there are questions after her presentations, I think there will be people in the room who are capable of answering those questions. So please, Jo, can you start Berre van's presentation?
With you during this webinar. Hello, everyone. Thank you for being able to present some of the iLIVE study findings with you during this webinar. It's a great pleasure for me to do that. Unfortunately, I won't be able to attend the webinar live as I will be flying back from my vacation in Peru back to the Netherlands, but I hope to still be able to share some interesting findings with you in this way. And before I do that, I would like to introduce myself. My name is Beri van Yildiz. Okay, let's first start with a little background. Research on preferences and needs of patients in the last phase of life has mainly focused on what constitutes a good death. And although there are some common core elements for a good death, including dying at a preferred place or relief of pain and psychological distress, preferences are still individual, unique, and different. The rapid increase in mortality rates during the COVID-19 pandemic worldwide and the challenges for end-of-life care during that period have also underscored the importance to understand and improve what people experience or should experience at the end of their lives. And we wanted, therefore, to have a better understanding of what preferences and concerns people have and how these are moderated by background characteristics. So the aim of our study was to describe preferences and concerns of patients in the last phase of life in 11 countries and to explore associations with socio-demographic, health-related and cultural characteristics. We used data from the baseline questionnaire within the iLIVE study, and preferences and concerns were assessed using 10 items of the IOLI measure, which was the attitudes of older people for end-of-life issues. And here you can read all the statements that were included. All 10 items were assessed on a 5-point Likert scale, ranging from strongly disagree to strongly agree. And we additionally added an option of I don't know. For information about social demographic and cultural characteristics, we asked patients about their age, gender, educational level, living situation, religion, and we had information about the country of residence. For health-related characteristics, physicians provided patients' main diagnosis, current treatment goals, and in functional status. And from the electronic patient files, we were able to retrieve information about the patient's date of death, which we calculated survival statuses with. And for analysis, we used descriptive statistics, and factor analysis were performed because we had selected 10 items from the IOLI statements on preferences and concerns. So with the factor analysis, we wanted to identify underlying constructs of preferences and concerns in our own data. And this gave us a factor scores, which we used as an outcome variable in the next step, which was the multivariable linear regression analysis to assess associations with social demographic, health-related, and cultural characteristics. Okay, to start with some descriptive statistics of the study population. The mean age of patients was 71 years old. Almost half of them was female and religious. About 43% indicated to be Catholic. More than half of the participants had a tertiary or university educational level and lived with relatives. And about 70% of the population was retired. With regard to health-related characteristics, almost 80% had cancer and survived and died within 1 month, and whereas about 30% survived beyond month 6. The factor analysis revealed 4 underlying constructs of preferences and concerns within the data. We named the first construct value and quality of life. We found that the following statements loaded positively on this first construct. The quality of my life is more important than how long it lasts. I fear being helpless and dependent more than I fear death. And I wish that death and dying were more openly discussed in our society. The statement of I want to be kept alive at all costs loaded negatively on this first construct. The second construct we named valuing social and spiritual support, as we found that the statements about spiritual support or religious support is important to me, and I want to be kept alive at all costs, and when I die I would like to be with my closest family and friends, all loaded positively on this second construct. The third construct was valuing autonomy, as we found that the statement of I want to be involved in decision making about the care I receive loaded positively on this construct, whereas I prefer the doctors to make all the decisions about my care, and I want treatment to control my pain completely, even if it left me muddled, loaded negatively on this construct. And as a fourth construct, we found beliefs about pain, including the statement about I believe most people are in pain as death approaches, loading very high on this fourth construct. Here you can see the percentages of the particular statements about valuing quality of life. The blue color represents the percentage of people agreeing with the particular statements. And as you can see, that's almost 80% of patients found their quality of life more important than how long life lasts. Slightly more than 70% feared being helpless and dependent more than they feared death. Only 18% of patients wanted to be kept alive at all costs, and slightly more than 70% of patients wished that death and dying were more openly discussed in society. Then the percentages about valuing social and spiritual support, we found that slightly more than 40% found spiritual religious support important, and about 80% would like to be with their closest family and friends when they would die. Valuing autonomy, we found that more than 90% of patients wanted to be involved in decision-making about the care they receive. About 45% of patients preferred the doctor to make all the decisions about their care. And almost half of patients wanted treatment to control their pain completely, even if it left them muddled. And then the last statement about pain belief, we found that 30% believe that most people are in pain as death approaches, and more than 40% did not know what to answer on this question or was neutral. And here you can see some first results of the multivariable linear regression analysis, in which we investigated associations with background characteristics. And when we put all the social, demographic, health-related, and cultural characteristics in the models, we found that the degree to which patients valued quality of life was explained by these background characteristics for 6%. And this percentage was 22 for social and spiritual support, 25 for autonomy, and 3% for pain belief. And these results indicate that valuing quality of life and beliefs about pain were hardly associated with background characteristics. And that's why in the next slide, I will only show significant associations for social and spiritual support and autonomy. For valuing social and spiritual support, we found that females were more likely to value social and spiritual supports compared to males. Also, those who lived with relatives were more likely to value social and spiritual support compared to those who lived alone. Religious people were more likely to value social and spiritual support, and those patients from Argentina and Spain were also more likely, compared to patients from UK, to value social and spiritual support, whereas patients from Germany and Switzerland were less likely, as they had a negative effect estimate, to value social and spiritual support compared to patients from the UK. With regard to valuing autonomy, we found that increasing age was associated with lower scores for valuing autonomy. and females were more likely to value autonomy compared to males. Those who had no education or primary educational level were less likely to value autonomy. Also, those who were religious or indicated to be religious were less likely to value autonomy, and patients from Germany and Switzerland were more likely to value autonomy compared to patients from UK, whereas patients from Slovenia and Sweden were less likely to value autonomy compared to patients from the UK, which was our reference group. Okay, so some conclusions of this study are that patients found quality of life more important than how long it lasts and preferred more open discussion of death and dying in society. We also found that almost all patients wanted to be involved in decision-making about treatment and care, while half of them preferred the doctor to make the decisions. Preferences and concerns about quality of life and beliefs about pain were hardly associated with background characteristics, while preferences and concerns about autonomy and social and spiritual support were associated with background characteristics. Based on our findings, we recommend clinicians to initiate conversations about preferences regarding the last phase of life, as we found that almost all patients wanted to be involved in decision-making about treatment and care, and most importantly, they indicated a wish for a more open discussion about death and dying in society. And it is recommended to not limit these conversations within the clinical setting, but extend these to public spaces as well, because increasing public awareness and fostering openness about death and dying can facilitate people to think about their values about the last phase of life. And this is essential for adequate discussions about preferences for treatment and care, and this may also contribute to meaningful end-of-life experiences. I would like to thank you for listening to my presentation. In case you have any questions, please reach out to me, and otherwise I'm sure Agnes will be able to answer any questions you have. Thank you so much and have a nice day.
So thank you, Berivan, for your clear presentation, and I hope you will arrive safely in the Netherlands later today. So if you have questions, you can, of course, contact Berivan directly, but you can also ask your questions now, if you like. So is there anyone who has a point for discussion or a question for clarification? If not, I think we can continue and to the last presentation of today, which is a presentation by Melanie Yoshi, junior researchers from the University of Cologne in Germany. And she's also going to talk about results from the iLIVE study, but in this case from the qualitative interview study that was an add-on of the big cohort study. And you will talk about how patients in the last phase of life deal with temporality. Melanie, the floor is yours.
Thank you. I will share my presentation. So you can see it now, right? Hopefully. Good afternoon, and thank you for your kind introduction. My name is Melanie Joshi, and I'm a registered nurse. I studied humanities and social sciences, and I am a research associate at the Department for Palliative Medicine at the University Hospital Cologne. Today, I would like to present the results of the iLIVE project, an international study which dealt with the expectations, concerns, and preferences of patients with a life-limiting illness. I will focus on results from the qualitative part of the study, as Agnes just said, and address how these patients deal with temporality. In our everyday lives, when we develop a sense of time, we feel like time flies, when too many things must be done in a too short a time. or we have too much time at our disposal and we feel bored. For patients with a life-limiting disease, the issue of time, though, is closely linked to the finitude of their own existence and the short time they have left to live. In an existential situation, such as the progression of a life-limiting disease, the focus can be primarily on oneself and the current situation, meaning the present. In a quantitative study, it was suggested that patients with advanced cancer live with a focus on the present, and that increased thoughts of the past trigger negative feelings. We as well asked patients about their time orientation, for example, whether they were more oriented in the past, present, or the future, but we particularly analyzed which topics occur in the respective time levels. That is how patients deal with limited time. 10 countries were involved in the interview study: Iceland, Norway, Sweden, the UK, Netherlands, Germany, Switzerland, Slovenia, Spain, and Argentina. We used a very broad sampling, independent of diagnosis and care setting and treatment. We included adults older than 18 years with a life expectancy of maximum 6 months and with the knowledge that a cure is unlikely for them. They had to give written consent to participate. The data collection was conducted as following. First, we assessed the socio-demographic data with the patient. Then we conducted the interviews. And then we wrote field notes after the interviews to reflect upon our impressions and provide additional material and information for the data analysis. In the fourth step, we made an interview summary in each country in English for every researcher of all countries to read, because the interviews were held in the local language. The interview guide consisted of 7 topics that were family, communication, decision-making, emotional pain and physical pain, spiritual comfort and transcendental beliefs, and perception of illness, and of course, time. It was based on the transcultural assessment model. Now I will come to the socio-demographic of our study population. We had slightly more male than female participants, more older patients, which may be explained by the assumption that a higher gatekeeping occurred with younger patients. We had more cancer patients than non-cancer patients in our sample, which is not unusual, as the cause of the disease could possibly be better estimated by physicians when patients had cancer. Most patients lived with a partner and had at least a secondary school leaving certificate. And how did we do our analysis? The first data coding was conducted in 3 countries: Argentina, Spain, and Germany. It was based on thematic analysis, and we found initial candidate themes, which were then developed into a code book. This was shared within all the researcher group of all countries, which then could add their quotes and themes and do the deductive analysis with the code book. Additionally, we invited critical friends, 11 researchers in Cologne, which reviewed the final code book and helped us to classify further. Now we'll come to the results. Here you can see the themes divided into the different time levels and classification for passive and active dealing with temporality. We found a time level beyond the normal time levels, past, present, and future, which is the future after death. There were themes that transcended the time levels, such as avoidance of thinking about one time level, the desire to die, or change view on lifetime. The presentation of all themes would go beyond the scope, therefore I will present one of each time level. When thinking about the past, several patients reached a moment of inner discussion that ended in satisfaction about their living, which assisted them to come to terms with past choices. One German patient said, for example, "Sometimes I also think, phew, what could you have done differently? Then I say to myself, no, I have gone this way. Patients considered it as a logical consequence that they would use the present like a trusted anchor to focus on more short-term outcomes because long-term goals seemed unachievable. This patient from Argentina showed a very pragmatic view, namely to live in the present because she did not know how long the future would last. She said, now that I've been diagnosed with recurrence, I think that the present moment makes much more sense. For the worries about the future, in this team were stated concerns about the outcome of practical issues, such as change in the care setting in the future or the future burden on their families. Worries regarding the fear of complications of their health situation or being a burden themselves both revealed a fear of losing independency and control. The Slovenian patient said, for example, I'm concerned about these little things that I'm sorting out right now. Oxygen, how to improve my meter, how to improve my breathing, in what shape I will be, and how many meters I'll be able to walk. The patients reported that they were more worried about their loved ones than themselves. Dying seemed to be easier to bear than the pain of their loved one's grief, which reveals a high level of empathy. This Norwegian patient said, for example, yes, I think about that, not for myself that I want to die. You will come to some kind of land. But I'm constantly thinking, how will it go with the others? Because I'm used to deciding and helping, so I'm more concerned about whether my wife will be able to cope. We found no general focus on a time level, as you have seen in the scheme. And we found that the unit of care, that is the patient and their loved ones, is of great importance beyond the death of the patient. Therefore, this emphasizes the importance of not only providing care until death, but with regard to the unit of care, this should be considered beyond the patient's death. This has been a pleasure to work with these researchers in the qualitative study. And if you are interested to know more about the iLIVE study or about the recently published article, you can find it here.
Thank you, Melanie, for again a thoughtful paper. There is one question in the chat that asks how you defined the 6 months prognosis in your interview study.
Yes, this was also like in the quantitative part of the study with the surprise question we just discussed. It's about if you ask a physician, would you be surprised if the patient would die within the next 6 months? And the physician answers with no, he would not be surprised or she would not be surprised.
And was this sort of prognostic estimate in any way discussed with the patient or not?
No, this was not discussed with the patient because it was irrelevant, because there was the second inclusion criteria that the patient was aware that this cure was unlikely, and therefore this was not discussed with this prognosis.
Mm-hmm. I was wondering, Melanie, in your introduction you stated that focusing on the past may be a sign of, or maybe may contribute to unfavorable situation for the patient, or negatively affect the well-being of the patient. Was that an association you also found in your interview study?
Well, it was yes, it was divided because in the category or theme about the past, we divided as in the other themes about active and passive dealing with the temporality. On the one hand, there was regrets and remorse, which might be a negative impact for quality of life. But on the other hand, there was also nostalgia and coming to terms with past choices, which I just presented. And those might be more positively connected to the present.
So would then your conclusion be that there is no clear positive or negative association with focusing on either of the time spans, that both can have favorable and unfavorable effects on how on patients' well-being?
Well, we did not measure effects. It was just insights into how how patients dealt with temporality in the real life. So I cannot answer this directly, but maybe give a hint that those themes are very fluctuant between passive and active dealing, and also between all the time zones, time levels.
Yeah.
So every patient who had primarily thoughts in the past may have been negatively affected or did only have thoughts in the past.
Yeah, I have lots of questions, but are there any questions from the audience? If not, can you perhaps talk a little bit more about what this means for healthcare providers? I mean, you suggested that they should perhaps focus a little bit also about on the future, in the sense of the future after the death of the patient. But can you give a little bit more clues of what that means, and how well, concretely what that would look like based on your results?
Well, I think just the knowledge to have this unit of care, that patients are more worried about their loved ones than themselves, gives a hint on that it is important to include those loved ones into the care they receive at the end of life. But I think this is also practice because a holistic care is normally usually used in palliative care. But I think it would be an implication for a better practice to involve or to be involved in the aftercare with the relatives or the loved ones. Just to check upon if everything is all right, if they need something, it might be an implication for a better care.
And to already address that before the patient actually dies, of course, because that's what the patient is concerned about while preparing for death and while being in this phase of life where death is imminent.
Right.
Yeah. Okay. Okay, then I think we can finish this meeting. Thank you very much, speakers, for your interesting presentations. I would like to end the meeting by drawing your attention a little bit to upcoming events organized by the collaborative, which include, of course, our next webinar, which is about children of parents who are dying of cancer. It will be a presentation by Professor Cherith Sample from Ulster University in Northern Ireland. And this webinar is on Thursday, 28th of November. You can register at the website of the collaborative and are warmly invited to attend this next webinar. And in addition to that, we have a few other events in November, 13th until 15th of November this year. We will have our 9th annual conference in Porto. You're very welcome to attend this conference and register for it, also on the website. And of course, we have our annual event of the summer school in May next year in Malaga, which is a very nice event where all attendees have the opportunity to engage in workshops on different topics in the areas of research, of education, of ethics, of clinical practice, to discuss care for the dying. I think that's it for now. If you want more information about the collaborative, please go to our website, bestcareforthedying.org. And for the rest, I would like to thank you very much for your presence and attendance today, and hopefully we'll meet at a next occasion. Thank you very much and have a nice day.